Chapter 11 Disorders of Sleep and Wakefulness and Their Treatment. As with pain, modern psychopharmacologists consider sleep to be a psychiatric vital sign, requiring routine evaluation and symptomatic treatment. Neurobiology of sleep and wakefulness. The arousal spectrum. Many psychopharmacologists approach insomnia or excessive daytime sleepiness as an important symptom that cut across many conditions and occur along a spectrum from deficit arousal to excessive arousal. And as arousal increases beyond normal, during the day there is hypervigilance and at night there is insomnia. On the other hand, as the arousal diminishes, symptoms crescendo from mere inattentiveness to more severe forms of cognitive disturbances until the patients have excessive daytime sleepiness with sleep attacks. The arousal spectrum is linked to the actions of 5 neurotransmitters: histamine, dopamine, norepinephrine, serotonin and acetylcholine. These neurotransmitter circuits as a group is called the ascending reticular activating system because they are known to work together to regulate arousal on a smooth continuum like a rheostat. The sleep-wake switch. There is another set of circuits in the hypothalamus that regulates sleep and wake discontinuously like an on-off switch and is called the sleep-wake switch. The on switch is known as the wake promoter and is localized in the TM nucleus of hypothalamus. The key neurotransmitter is histamine. The wake promoter promotes histamine release. This occurs both in the cortex to facilitate arousal and VLPO to inhibit sleep promoter. The off switch is known as the sleep promoter and is triggered as the day progresses. The circadian wake drive diminishes and the homeostatic sleep drive increases. It is located in the VLPO nucleus of the hypothalamus. The key neurotransmitter is GABAA, which inhibits wakefulness. 2 other sets of neurons are regulators of the sleep-wake switch. The first are OREXIN or hypocretin-containing neurons of the lateral hypothalamus. These stabilize and promote wakefulness and are lost in narcolepsy, especially narcolepsy with cataplexy. The second are melatonin-sensitive neurons of SCN in hypothalamus. SCN is the brain's internal clock or pacemaker and regulates circadian input to the sleep-wake switch in response to how it is programmed by hormones such as melatonin and by light-dark cycle. The homeostatic sleep drive increases the drive for sleep as the day goes on, presumably due to fatigue, and diminishes at night with rest. The novel neurotransmitter adenosine is linked to homeostatic drive and appears to accumulate as the drive increases during the day and diminishes at night. Interestingly, caffeine is now known to be an antagonist of adenosine, and this may explain in part its ability to promote wakefulness and diminish fatigue. Disorders characterized by excessive daytime sleepiness can be conceptualized as the sleep-wake switch being off during the daytime. Wake-promoting treatments such as modafinil given during the day promotes wakefulness by release of histamine from the TMN neurons, which is hypothesized to act on that. On the other hand, insomnia can be conceptualized as sleep-wake switch being on at night. This can be treated either by agents that enhance GABA actions or agents that block the action of histamine and act at postsynaptic H1 receptors. Disturbance in circadian rhythm can be conceptualized as either phase delayed or phase advanced. In phase delayed, the wake promoter and sleep-wake switch is on too late in a 24-hour cycle. May be seen in depressed patients and even in normal adolescents who still have their sleep-wake switch off when it is time to get up. Giving such individuals morning light and evening melatonin can reset the circadian clock. And in phase advanced, the wake promoter and the sleep-wake switch is being turned on too early in a normal 24-hour cycle. It is quite common in elderly people, and giving these individuals evening light and morning melatonin can reset their clock. Histamine. Histamine is the ultimate target for many wake-promoting drugs via downstream histamine release and also sleep-promoting drugs that are antihistamines. It is produced from the amino acid histidine, which is taken up into the histamine neurons and converted into histamine by the enzyme histidine decarboxylase. The action is terminated by 2 enzymes working in sequence. The first one is histamine N-methyl transferase, which converts histamine to N-methylhistamine. And the second one is MAO-B, which converts N-methylhistamine to N-methyl indole acetic acid. Additional enzymes such as diamine oxidase can also terminate histamine action outside the brain. Histamine is likely to diffuse widely away from its synapse as there is no apparent reuptake pump for it. At a glutamate synapse containing NMDA receptors, it can act in an allosteric modulator site called the polyamine site to alter the action of glutamate at these NMDA receptors. The function of this action is not well clarified. There are several histamine receptors. The first is the postsynaptic H1 receptors. When histamine itself acts on these, it activates G protein linked second messenger system, which in turn activates phosphatidylinositol and the transcription factor CFOS. And the result is wakefulness, alertness and pro-cognitive actions. These are also the targets of antihistamines and cause sedation, drowsiness or sleep. The second one is the postsynaptic H2 receptors. Their function in brain is still being clarified, but apparently it's not linked directly to wakefulness. The third one is presynaptic H3 receptors, and these function as autoreceptors, that is, when histamine binds to these receptors, they turn off further release of histamine. Several H3 antagonists are in clinical development as a novel approach to wake-promoting and pro-cognitive drugs. The last one is H4 receptors and are not known to occur in brain. Interestingly, all histamine neurons arise from a small bilateral nucleus of the hypothalamus known as the tuberomembrane nucleus. Insomnia and hypnotics. What is insomnia? Insomnia has many causes, including both sleep and psychiatric disorders. It can also contribute to onset, exacerbation, or relapse of many psychiatric disorders. Primary insomnia is a condition with too much arousal both at night and during the day, and thus the patient is not sleepy during the day despite having poor sleep at night, and might be a symptom that can progress to the first major depressive episode. Chronic treatment for chronic insomnia. A major reconceptualization is that insomnia can be chronic and that it may need to be treated chronically, changing the paradigm that insomnia is treated by attacking the underlying cause and not by giving chronic symptomatically masking treatment with hypnotics. This was mainly due to safety concerns during the barbiturate era and later during the benzodiazepine era, and with agents in the past that had half-lives too long, causing drug accumulation and hip fractures from falls, especially in the elderly when used every night, or causing next day carryover effects and memory problems. And finally, due to agents with half-lives that were too short, with their effects wearing off before it was time to wake up, causing insufficient sleep maintenance and nocturnal awakening, as well as restless and disturbed sleep in some patients. Newer agents don't have problems of tolerance and withdrawal effects, including rebound insomnia, and thus has no restriction against chronic use. These include the melatonergic agent Ramelteon and the sedating antidepressant Rosidone. Psychiatric insomnia and the GABAA PAMs. Insomnia, as discussed in previous chapters, is perhaps the most frequent residual symptom after treating depression and anxiety disorders, and thus it makes intuitive sense to utilize hypnotics as augmenting agents to the first-line treatments. Interestingly, not many studies are available for insomnia associated with psychiatric disorders, leading to fewer clear guidelines. But recent studies have shown that hypnotics may enhance remission rates both for patients with major depression and GID who had insomnia. GABA PAMs as hypnotics. As the name suggests, these act at GABA receptors to enhance its action by binding to a site different from where the GABA itself binds. These include the benzodiazepines and the Z drugs. Benzodiazepine hypnotics. As mentioned before, because benzodiazepines do not have ideal half-lives for many patients, binds to GABA receptors in a manner such that tolerance and withdrawal generally develops and causing long-term problems. Therefore, they are generally considered second-line agents for use as hypnotics. That being said, when first-line agents fail to work, benzodiazepines still have a place in the treatment of insomnia, particularly for insomnia associated with various psychiatric and medical illnesses. They bind to 4 of the 6 GABA receptors, alpha 1, 2, 3, and 5. The alpha 1 subtype is known to be critical for producing sedation, anticonvulsant actions, and possibly amnesia. The alpha 2 and 3 are likely linked to anxiolytic, muscle relaxant, and alcohol potentiating actions. And alpha 5 is mostly found in hippocampus and may be linked to cognition and other functions. Coming on to the Z drugs, these are non-benzodiazepine hypnotics and are also GABA PAMs. These bind to GABA receptors in a way that does not cause a high degree of tolerance, dependence, or withdrawal. These include zaleplon, zolpidem, and zopiclone. These can bind to 4 of the 6 GABA receptors, that is alpha 1, 2, 3, and 5, but are more alpha 1 selective. Zolpidem CR has extended duration of action of about 6 to 8 hours. Zolpidem sublingual has faster onset and is given at a fraction of the usual nighttime dose for middle of the night administration for patients who have middle insomnia. As zopiclone is S enantiomer of zopiclone and has best long-term studies. Melatonergic hypnotics. Melatonin is a neurotransmitter secreted by the pineal gland and acts specially in the suprachiasmatic nucleus to regulate circadian rhythm. It acts at 3 different sites. The first is melatonin 1 and it mediates inhibition of neuron in the SCN, and this helps to promote sleep and decrease the wake promoting actions of the circadian clock or pacemaker that functions there. The second is melatonin 2 receptors. These mediate phase shifting and circadian rhythm effects of the normal sleep-wake cycle. Third site is melatonin 3 is now known to be the enzyme NRH, which is probably not involved in sleep physiology. Ramelteon and tasimelteon are MT1-2 agonists marketed for insomnia. These agents improve sleep onset when used for several days in a row and is mostly used for initial insomnia. The melatonergic antidepressant agomelatine shifts circadian rhythm in depressed subjects with phase delay. Serotonergic hypnotics. Trazodone. It is effective as a hypnotic when given at a lower dose than that used as an antidepressant. At lower doses, only its H1 antihistamine and alpha-1 antagonist properties are recruited and can be given once at night as it has half-life of around 6 to 8 hours. Interestingly, it accounts for up to half of all prescriptions of hypnotics, although it was never officially approved or marketed as hypnotic. Histamine H1 antagonists as hypnotics. Histamines are popular as over-the-counter sleep aids, but it's difficult to separate the antihistamine action of these agents from its anti-muscarinic actions, causing side effects such as blurred vision, constipation, memory problems, dry mouth, hangover effects, tolerance, and weight gain. Doxepine is a tricyclic antidepressant and at very low doses is a H1 selective antagonist. Due to its very high affinity for H1 receptors, it requires just 1 to 6 mg for its hypnotic actions. Also, it has shorter half-life, thus reducing the next day hangover effects, does not cause weight gain or tolerance. Dopamine agonists and alpha-2 delta ligands for insomnia associated with restless leg syndrome. The first-line treatment is with dopamine agonists such as ropinirole or pramipixole, and the second-line treatment is with alpha-2 delta ligands such as gabapentin or pregabalin. Coming on to behavioral treatments of insomnia. Sleep hygiene and cognitive behavioral approaches are first-line treatments for primary insomnia and adjunctive treatments for insomnia of any cause. Who cares about slow-wave sleep? Deficiency of slow-wave sleep can contribute to a sense of lack of restorative sleep and daytime fatigue. In patients with depression can enhance symptoms of fatigue, apathy, and cognitive dysfunction. And in patients with pain syndromes can cause enhanced daytime experience of pain. Only a limited number of agents are known to enhance slow-wave sleep. These include alpha-2 delta ligands such as gabapentin and pregabalin, the GABA reuptake inhibitor tiagabin, and 5-HT2A2C antagonists such as trazodone and GHB. OREXIN antagonists as novel hypnotics. OREXIN neurons are localized extensively in certain hypothalamic areas, for example, lateral, posterior, and periphonical areas. These neurons make neurotransmitters orexin A and B, which are released from their neuronal projections all over the brain, but especially in the monoamine neurotransmitter centers in the brainstem. The postsynaptic actions of the orexins are mediated by two receptors. Orexin 1 is highly expressed in the brainstem locus coeruleus, the site of noradrenergic neurons. Feeding behavior and reward is mostly mediated by these. And orexin 2 is highly expressed in TMN, the site of histamine neurons. The effect of orexin on wakefulness is largely mediated by these. Orexin A interacts with both orexin 1 and 2 receptors, but orexin B interacts only with orexin 2 receptors. Lack of orexins is associated with narcolepsy. Dual orexin receptor antagonists or DORAs block both orexin 1 and 2 receptors. They have shown efficacy in treatment of insomnia, and some are advancing to clinical trials. And it appears that acute, short-lived and intermittent temporary blockade of orexin receptors is well tolerated, without the induction of narcolepsy-like syndrome. Examples being elmorexant and suvorexant. And they appear to improve both initiation and maintenance of sleep in human subjects, without the side effects. Coming on to single orexin receptor antagonists. SORA1 agents are not particularly robust in treating insomnia, but are in development as possible treatments to reduce craving for drugs and food. Some examples are listed below. SORA2 agents, on the other hand, have promising preclinical results treating insomnia. Some examples are given below. Excessive daytime sleepiness, that is hypersomnia, and wake-promoting agents. What is sleepiness? Daytime sleepiness is important to assess, even though patients often do not complain about it when they have it. Comprehensive assessment requires additional information to be obtained from the patient's partner, augmented with subjective rating scales such as Epworth Sleeping Scale and objective evaluation such as overnight polysomnography or next day multiple sleep latency or wakefulness testing. What's wrong with being sleepy? Patients with excessive daytime sleepiness have problems with cognitive functioning, as they can often activate their DLPFC but cannot sustain it. Mechanism of action of wake-promoting agents. Modafinil. It is a proven wake-promoting agent whose exact molecular mechanism of action remains debated. It is a weak DAT inhibitor, enhancing tonic dopamine activity once dopamine is released and the cortex is aroused, leading to activation of wake-promoting TMN neurons and the lateral hypothalamus, leading to the release of both histamine and orexin, which stabilizes wakefulness. But interestingly, release of orexin does not appear to be necessary, as modafinil promotes wakefulness in patients who have lost the hypothalamic orexin neurons in narcolepsy. ARMODAFINIL. As the name suggests, it is the R enantiomer of modafinil. Pharmacokinetic properties of ARMODAFINIL could theoretically improve the clinical profile of modafinil, with later time to peak levels, a longer half-life, higher plasma drug levels at 6 to 14 hours from oral administration, which leads to greater activation of phasic dopamine firing and possibly eliminating the need for a second daily dose. Stimulants. The two principal stimulants used as wake-promoting agents are methylphenidate and amphetamine, especially D-amphetamine. At doses to treat sleepiness, they enhance the synaptic availability of dopamine and norepinephrine and thereby improving wakefulness. Methylphenidate is a known inhibitor of DAT and NET, whereas amphetamine is a known competitive inhibitor of DAT, NET and VMAT2. Caffeine was originally thought to work as an inhibitor of enzyme phosphodiesterase. Now appears to act mostly as an agonist of endogenous neurotransmitters called purines, an important one being adenosine. Certain purine receptors are functionally coupled with dopamine receptors, such that the action of dopamine at D2 receptors are antagonized when adenosine is binding to its receptor. And thus, caffeine indirectly promotes the action of dopamine. GHB is also known as sodium oxybutate or Xyrem, and is approved for the treatment of excessive daytime sleepiness associated with narcolepsy as well as for cataplexy. It is also sometimes used off-label to treat refractory cases of fibromyalgia as well as in treatment of alcoholism in some European countries. As studied in previous chapters, GHB is a natural product present in brain with its own receptor. It is found from GABA and also acts at GABA-B receptors as a partial agonist. Because of its abuse potential and colorful history, it is scheduled as a controlled substance and its supply is tightly regulated. Has been labeled as a date rape drug as it has occasionally been used with alcohol for this purpose. And because of growth hormone surge that accompanies slow wave sleep, it was abused by athletes as a performance enhancing drug, especially in the 1980s.